quality improvement here, and I welcome you today to the University of Ottawa Division of Geriatric Medicine and Academic Grounds, which will be presented by Dr. Molnar today. We're very thankful to get such a large showing of people from far coming online, and we welcome you to our talk today. Our topic today is review and discussion of measures of clinical significance in Alzheimer's disease-modifying therapy or the anti-amyloid antibody infusion trials. Certainly a very topical point of discussion, and we're lucky to have Dr. Molnar presenting to us today. We'd also like to thank Liz Lacasse for a huge amount of effort in helping us set up today, both with the technical support and getting the room and everything organized. We wouldn't be able to do this without you. So Dr. Molnar is a full professor of medicine at the University of Ottawa, whose interest in dementia treatment started early in his career when, as a resident in internal medicine in 1993, he presented medicine rounds on the first cholinesterase inhibitor, Tacrin. After completing his residency in geriatric medicine, he went on to obtain a master's degree in epidemiology, where his master's thesis was once again focused on dementia. During those years in the early 1990s, under the direction of members of the University of Ottawa group, some of whom had studied under Dr. Gord Guyot, he studied the concept of minimal clinically important difference, MCID. He merged these interests in dementia and MCID and was the lead investigator on a 1999 study of MCID for the MMSE. This may be one of the first MCID studies in dementia. It is fair to say that Dr. Molnar is one of the pioneers in measures of clinical significance, in particular MCIDs in dementia. This last statement is supported by the fact that Dr. Molnar was the lead investigator and first author in one of the first systematic reviews of measures of clinical significance in dementia, published in the Journal of American Geriatric Society in 2009. Since, in 2024, he's been involved in dozens of papers and hundreds of presentations, all focused on dementia. Later, Dr. Molnar co-authored an article titled Potential of Anti-Amyloid Therapies for Patients with Alzheimer's Disease in Canada. Today, Dr. Molnar, as a pioneer in the field, will apply his understanding of measures of clinical significance in dementia, gained over 3+ decades of study in 2 centuries, to disease-modifying therapy trials, anti-amyloid antibody therapies. He wants me to let you know that his goal is to increase depth of knowledge and raise level of discussion. The goal is to avoid entrenched, inflexible beliefs that are leading to polarization within the field. He asks that we keep our minds open and discuss to learn rather than debate to win. Dr. Molnar.
Thank you, Dr. Roy, for that introduction. As you heard, I'm going to review and discuss measures of clinical significance in Alzheimer's disease, specifically as it pertains to the anti-amyloid therapies. Giving this presentation, I'm going to wear 2 hats. One is as a member of the University of Ottawa Division of Geriatric Medicine, and the other is as chair of the Canadian Geriatric Society Alzheimer's Disease Modifying Therapy Patient Perspective and Communication Special Interest Group. In terms of conflicts of interest, I don't accept any money from the pharmaceutical industry. When I go to dinners, I pay my own meal. I do stand up when I see methodological issues that need to be addressed. So I have published on the methodology of cholinesterase inhibitors and the MANTine RCTs, indicating that all RCTs that used last observation carried forward as the primary analysis were likely invalid with exaggerated results. I brought this to FDA, to EMA in Europe, and to Health Canada. So I do stand up and speak up when it's necessary regarding methodological issues, and this will be an example of that. Now, I do acknowledge the majority of RCTs have been done by the pharmaceutical industry, and that some academics need to work very closely with them. I feel we benefit from having that heterogeneity where some do work with pharma and some, like myself, are made at arm's length, sort of a diverse ecosystem. So I think there's room for both in this conversation. The objectives are to briefly outline the controversies in this field, to discuss methodologies that are used to employ minimal clinically important difference in dementia drug trials. And this is critical to whether a trial is positive or negative. This is foundational. To present reviews of MCIDs in Alzheimer's disease, to discuss the limitations, validity, and application of these MCIDs in these disease-modifying therapies. I'm going to use disease-modifying therapy and disease-targeted therapy interchangeably. And then finally, we'll discuss how can we move this field forward, what improvements can be made in measures of clinical significance. So as Dr. Goy mentioned, our group published the first study of MCID and dementia in 1999. So we started discussing this around 94, published this study with lead author Darren Burbach, myself, Bill St. John, and Malcolm Hing. Then our group, with Malcolm Hing again and Dean Ferguson, published a systematic review of measures of clinical significance in dementia drug trials. This appears to be the first systematic review in this field. So I think it's factually correct to say this group of physicians are the pioneers in MCID and dementia. As a pioneer, I feel a certain level of responsibility to weigh in when I see MCIDs maybe being misunderstood, maybe being used suboptimally, and when I see opportunities to improve the field. So this talk is me weighing in as one of the pioneers in the field. So in that 2009 systematic review, we had a couple of messages that still ring true today. We found that patient and caregiver-centered measures of clinical significance have not been adequately studied or integrated into dementia drug RCTs. More empirical research is required on patient and caregiver perspectives, not just clinician, but patient and caregiver perspectives regarding what constitutes a clinically important change. And these measures should be in terms that reflect meaningful real-life improvement for patients and caregivers themselves. We also indicated funding agencies should consider initiating requests for proposals focused on the determination of minimal clinically important differences, or MCIDs, of outcome measures employed in dementia research. Those were the messages in 2009. Those are the messages today. So that's where we're going to end up. The other thing we introduced in 2009 was an MCID responder analysis. So not only did we look at MCIDs, we looked at how they could be integrated into the analysis of drug trials. So this is a standard responder analysis that was used in dementia drug trials in the days of Aricept coming out in the 90s. What you can see in the middle, so you have two groups, the treatment group, the control group. In the middle, neither of them have changed. They haven't surpassed any MCIDs. And this is assuming there are two MCIDs, a lower level one and a higher level one. So they can move in one direction where they have improved greater than the lower level MCID, or they've improved greater than the higher level MCID, or move in the other direction. They have deteriorated beyond the level of the lower level MCID or higher level MCID. And you see how the two groups compare, and what you want to see is a bit of a skewing towards the left, towards the improvement. And what that tells you is that there may be a signal in the data, a signal that's not captured by the gross group-to-group comparisons where you just see two group averages. That's a very blunt instrument. And this digs in a little bit deeper to find out, are there hidden subgroups we don't know about? And this is a technology I think we need to look at again in these new trials. We pointed out that the measures of clinical importance vary according to perspective, whether you're the patient with the disease, the healthy older person, the caregiver, society in general, physicians, researchers. So different perspectives will yield different MCIDs. And Dr. Cummings has reinforced that by saying clinical meaningfulness will depend on the goals as a stakeholder. So MCID is not a unitary concept. You can get different MCIDs depending on where you sit at the table and what your involvement in this issue is. That was in the papers. Thinking about this over the years, I think we have a hierarchy of MCIDs. This is a new concept that I haven't seen anywhere. And I think it does fit the pyramid model. At the very bottom, you have minimally detectable differences. So patients can tell they're on the drug, but the changes aren't meaningful. It's just a slight difference. Then I think we have a variety of MCIDs that are increasingly higher and harder to pass. So the patient MCID type A means it's an important difference to the person, but they're not considering side effects or risks or costs. And I think that's what's being talked about in the trials right now. Patient MCID type B, they're starting to think about the side effects and risks. What could happen to me if I take this? But they're not thinking about the cost, the financial cost. Patient MCID type C, they're thinking of the risk, side effects, and financial costs. So those are the patient MCIDs. And above that, an even higher level MCID is a societal MCID. In a single payer public healthcare system, which is a zero-sum game, it's a set pie, is the benefit sufficient to shift money from another area of healthcare? That is a much bigger question that we have to answer as a society. You can also envision it as a step-up bar graph. So at the bottom is statistically significant difference. You can mathematically tell the groups apart, but nobody can tell. Human beings can't tell the difference. Minimally detectable difference means you can tell there's a little difference. Then there's the MCID A. You're not looking at side effect, risk, or cost. MCID Z, you're looking at side effect, risk, but not cost. MCID, you're looking at all of them, side effect, risk, and cost, getting increasingly higher. and then societal MCID. So MCID is not unitary. It depends whose point of view you're looking at it from. That was 1999 to 2009. So let's look going forward. I'm going to try to be balanced. I'm going to try to support both points of view, but I'm also going to criticize both points of view. So I'm going to balance my criticism. So I looked at a number of papers, and these ones really stood out. These came out 14 years after our review in the Journal of the American Geriatric Society. When I refer to these papers, I'm just going to refer by the name of the first author. So I'm going to refer to the Peterson paper, Muir et al., Hamilton et al., Langto et al., and then Dr. Cummings' perspective. So those are the ones that are foundational. And if people are interested, these rounds will eventually be on YouTube, so you'll be able to see this again if you want. You just have to email me for a copy of the YouTube. I put my email address at the top, and I put it at the back. Or you can even ask me for the slides. I'm happy to share. We need to acknowledge that these monoclonal antibodies are only for a small minority of patients. So this was published in Neurology. They looked at Mayo Clinic study of aging participants. They found 237 who had MCI, or mild dementia with a positive PET amyloid, or amyloid PET. And then they applied the lecanemab clarity inclusion criteria, and that immediately dropped to 237 to 112, so 47% of the initial group. Then they applied the exclusion criteria, and it dropped them to 19, so 8%. So this is a quick funneling effect. They were funneled by comorbidities and neuroimaging findings. So this tells us this is for a very select group of patients, and we have to find those patients and target those patients very carefully. But this also feeds into part of the controversy, which is the equity argument. This is a busy slide, but it's an important one. We need to acknowledge, before going into the science, we need to acknowledge the polarization or over conflict that's occurring in this field as people have very entrenched beliefs. And now I'm going to upset everyone by saying this, but I have seen this throughout my career where people have entrenched beliefs and they use scientific methods to prove their belief. That is not science. You do science to find the truth, even if it does not support what you want to believe. But I've seen this going on over and over for decades. I encourage people to, do a little bit of self-reflection and ask, are my entrenched beliefs holding me back from listening to the other side, from learning? Am I debating or am I discussing? So I think there are two groups. There are the enthusiasts and the skeptics. The enthusiasts would focus on new hope. They say these drugs shine a light on dementia, brings it out of the shadows, makes it cutting edge and attractive to researchers, clinicians, funders. They say even if the antibodies only help a small percentage, we could potentially get a lot of people with early, pre-MCI, MCI, early dementia coming to us much earlier. Even if they don't qualify for the drug, we can do so much good by instituting all of the brain health preventative healthcare measures. That indirect effect might be huge. They'll say this is an unstoppable juggernaut. This is happening. You can fight this, but it's futile. It's a futile and a waste of time to try to fight this. This is happening. We may as well be involved to ensure this is done as well as it can be. And there are many treatments coming out. There are 21 drugs in phase 3 trials. So we should build the infrastructure and gain experience. So those are the enthusiasts. Then there are the skeptics. And both of them have valid points. They need to listen to each other rather than have an entrenched belief and fight with each other. So they'll say the healthcare system is a zero-sum game and is already underfunded. This may take resources and money away from other areas of dementia care and healthcare. Even if the drug costs are covered, it's still going to use staff time in our clinics, so they'll have less time for traditional healthcare. Even if the drugs are covered, the system still has to pay for PET scans, MRIs, emergency department visits, hospitalization, blood tests. So these are expensive treatments that may benefit a small minority at the cost to the large minority, to the large majority. So these are valid concerns that need to be well managed because this could cause a lot of harm if this is not managed well. They point out we don't have the infrastructure, true. And then they point out the inequity. There are disparities in healthcare access. So if you live in a rural region, you're less likely to benefit. Yes, eventually we could get the sub-Q formulations, but you need to be near an emergency department with neurologists and MRI scans who can monitor this and get help for you should you have one of the side effects. If you're of low income, you're less likely to have insurance to cover the costs. So there are some real equity issues. So we have to understand there's an undercurrent to this discussions that go on. Some people recognize their own bias, some don't. And some of what is said is not just scientific, it's emotional. So there's a lot going on in these discussions. The final thing the skeptics say, which is going to be the focus of this talk, is that the outcome measures, the group-to-group comparisons in these trials, do not meet previously published thresholds for minimally clinically important difference. And that is true, and that's what we're going to talk about. So what is an MCID? What's the definition? I'm going to keep coming back to one point, that meaningful change is not equal to meaningful enough change to counterbalance cost, burden, risk. Those are two different concepts. So MCID was first proposed or published in 1989 by Yashki, Singer, and Guy. The definition was the smallest difference in score in the domain of interest which patients perceive as beneficial and which would mandate, this is important, in the absence of troublesome side effects and excessive cost, a change in the patient's management. That in the absence of troublesome side effects and excessive costs, which is true of these medications, they are expensive and they have side effects, that has been dropped from more recent definitions. If you look at the recent definitions of MCID, the smallest change that patients perceive as important that would prompt a change in the care plan, smallest difference that patients perceive as beneficial. That, I think, was a mistake. We need to get that part in red back in because at least it acknowledges there's another side to this equation. There are a lot of costs. There are, and I'm going to put all of this under cost, there are risks of ARIA, so edema, brain hemorrhage, infusion reaction, cost, need for PET or LP, which can be replaced with blood-based biomarkers, need for multiple MRIs, need for 18 months infusion, which may be replaced by subcutaneous, need to go to emergency departments, the worry, if I was on this drug, I would be worried. Caregiver burden. So there are a lot of costs that need to be thought about when we're talking about MCIDs, and it seems to have been dropped from the definition. So did the drug trials for these disease-modifying therapies surpass the MCIDs? No. But we've been saying that for 3 years. We've all been very honest about this and talking about what does this mean. So they didn't cross that hurdle. This is a landmark paper by our Canadian colleagues in Calgary and Toronto by Muir, Hill, Black, and Smith. And Dr. Smith is on the line today. I would recommend if you're only going to read one paper in this field, this is the paper to read. So they found 10 studies that looked at MCID and dementia. You see our study in 1999 was the first one. We are the pioneers in this field. The second study was 8 years later. So 10 studies in the field. And this boiled down to this one table. And this one table, I'm going to use part of this table in subsequent slides. So what they found is we're going to look at MCI and mild Alzheimer's. We're not going to look at moderate severe. We're going to look at ADAS-Cog, CDR, sum of boxes, and IADRS. So we're going to look at part of this. So the MCID for ADAS-Cog for MCI was 2 to 3 points. For mild dementia, 3 points. For CDR, sum of boxes, for MCI, the MCID was 1 point. For mild Alzheimer's, 2 points. For IADRS, for MCI was 5 points, for mild Alzheimer's, 9 points. So I'm going to use part of that in the subsequent slides. So in the Clarity trial of lecanemab, when they looked at the clinical dementia rating sum of boxes, which goes from 0 to 18, with 18 being worse, they found the difference was 0.45. So if you look at the table, which is selected from the previous table, that did not cross the MCID, which is 1 for MCI and 2 for mild dementia. If you, in the Clarity trial again for lecanemab, for ADAS-Cog, the 14-item cognitive subscale of the Alzheimer's Disease Assessment Scale. This is a scale that's been used in all sorts of cholinesterase and your trials, memantine trials. This is the most common scale. The difference was 1.44. This did not meet the MCID. If you look at the table, the MCID for MCI was 2 to 3 points, and 3 in MCI, and 3 points for mild dementia. Moving to the next drug, Trailblazer study for donanemab, the clinical dementia rating sum of boxes, difference was 0.67. Once again, did not meet the MCID. For MCI, that's 1 point for mild dementia, 2 points. And once again, Trailblazer for donanemab, the Integrated Alzheimer's Disease Rating Scale, IADRS, is a 144-point scale. The difference was 3.25 points, did not meet the MCID. Look at the far right of that table. It's 5 points for MCI and 9 for dementia. But we've known this for a long time. That's why I'm not going this into detail. We've known they didn't cross this. The skeptics are correct, but the enthusiasts have been honest about this also. So what does this mean? Does this mean that trials failed? Is this a measurement area? What does this mean? Now, in response to this, some authors have said the MCIDs should not be used to compare treatment and control groups. They said the MCIDs were designed to compare patients to themselves, not to compare groups. That, however, does not match the description of the MCID in the 1980 study that introduced them. So Yashki, Singer, and Guyot described it as this information will be useful in interpreting questionnaire scores, both in individuals and in groups of patients participating in control trials. So they were looking at groups. So here, I know I'm going to upset some people once again, but it's important to be honest. If all these trials across the MCID, everyone would be saying these trials are all positive because they passed the MCID. If they now change that interpretation because they didn't cross the MCID, that is a sign of bias. That may be unconscious bias. So if now they're arguing against the MCID, whereas they would have been happy with it if the trial crossed it, that's a sign of bias, and they need to self-reflect. I know I've upset people by saying that, but it's really important that we don't lower the bar. Some people will also say not using the MCID for group-to-group comparisons is not lowering the bar. It is 100% lowering the bar. You cannot lower the bar with a treatment that costs tens of thousands of dollars, that has infusion reactions, that causes bleeding in the brain, edema in the brain, and in rare instances death. You need to have a reasonable bar to jump over if you are scientific. Not if you have firmly held beliefs, but if you're scientific, you need to have a reasonable bar. And this is one of my strongest slides and strongest points. We have to control our bias. We don't gain anything by lowering the bar so everyone can clear it. I love that statement. So why did the outcomes not cross the MCID thresholds? There are a number of reasons. Maybe the drugs don't work. Maybe they don't work well enough. So that's one interpretation. There are a number of other interpretations that say this is a measurement error. We're not measuring this properly. So there's something called type 2 or beta errors. So if you have a drug with a positive effect, but you put it through a small trial with inadequate sample size, inadequate power, you can get a false negative result. So you can get a false negative result with a positive drug, with an effective drug. That's called type 2 beta error. It's possible this happened because FDA, while it likes MCIDs, it doesn't make decisions based on MCIDs. So FDA will look for trials that establish statistically significant difference, and that takes 18 months. If you want to prove MCIDs, you may need much larger trials than we're done, or much longer trials. But why would a pharmaceutical industry spend tens of millions of dollars to do that if the FDA doesn't want it? So the FDA doesn't require the trials be powered or long enough to establish MCID. So it's not a surprise to me that these trials did not surpass the MCID. I kind of expected it. So that's one issue. The trials may have been too small because they're not required to be powered for this. There may be time to effect. We're going to get into that in more detail. It may take longer for preventative therapy to work. The last point has bothered me since I was a resident, since I first started looking at trials. The average treatment effect may dilute out or hide positive response of subsets of patients. And that's always bothered me for 30 plus years. And can you truly call a medication ineffective if there's a subset of a patient that responds very positively? And on this drawing on the right, you can imagine different types of response. So you get some super responders who are going from the left, where it says placebo group, all the way to the right. So you can see at the top, there's the MCID average difference. The average difference is less than the MCID, but you might have super responders that cross from one side to the other. You could have all sorts of responders. You could have non-responders. You could have patients that are getting worse on the drug, mild, moderate, super responders. It could all be hidden in there. The group-to-group comparison is a very blunt tool that can hide a lot of signal. So that has always worried me. And Muir et al. Repeated that. They said, the use of average differences obscures the possibility that a significant minority of treated patients may have had a clinically meaningful response. They said to better understand the results, the trials should report the proportion of patients in the drug and placebo groups that had a clinically meaningful decline by applying MCID thresholds to each individual patient. That is MCID responder analysis that we proposed in 2009. That allows you to calculate risk ratios and number to treat, which are staple metrics of evidence-based medicine. So that gets into a language that everyone knows. They calculated the number needed to treat for donanemab, and it was 8.3. So you have to treat 8.3 patients for 18 months to prevent one patient from having a meaningful decline in CDR global score. So you say, is that good or is that bad? Because what are number needed to treat? Is that a good one? The other thing you have to counterbalance that with is number needed to harm. So if a drug has no harm, then you can focus on number needed to treat. But these drugs can cause infusion reactions, brain edema, brain hemorrhage, and early death. So you do need to look at number needed to harm. So let's look at that number needed to treat of 8. So I like this website, the number needed to treat.com or the NNT.com. It has all sorts of disease. You can plug in disease, get all the number needed to treat. I pulled one out. So blood pressure medications for 5 years to prevent death, heart attacks, and strokes. So you have to treat 125 patients for 5 years to prevent death, 67 for 5 years to prevent stroke, 100 for 5 years to prevent heart attacks or fatal sudden cardiac death. So that gives you a little perspective on the number needed to treat. And then where it says harms in NNT, I think that's numbers needed to harm. So this is giving you a little bit of perspective of what a number needed to treat of 8 might mean. Camilla Wong published this in the Canadian Geriatric Society Journal of CME. It doesn't have number needed to harm as before. We need to know number needed to harm, but it does look at NNT. So for comprehensive geriatric assessment, the number needed to treat is 17 to 25. There's probably no harm in doing a CGA. For a statin to prevent cardiovascular mortality in established coronary artery disease, 34. For alendronate primary prevention of vertebral fracture, 50. For live attenuated varicella zoster virus to prevent herpes zoster, 50. For Pixaban to prevent stroke, systemic embolism, 51. It just gives you some perspective on the number needed to treat, because in some publications they go 8, 8's off. Well, it depends on the number needed to harm. 8 may not be off. So Cummings, in his perspective in 2025, wrote, the data from the trial may be used to generate MCIDs that can be used in responder analyses to determine if the number or percentage of patients exhibiting meaningful deterioration is greater in the placebo group compared to the active therapy group. So this is, responder analysis has been used throughout dementia drug trials. This is from Aracel, from donepezil. So here you can see there's donepezil, 10 milligrams, 5 milligrams, and placebo. And what they look, how many of these fit in these different categories? No change, or minimally improved, moderately, markedly improved, minimally worse, moderately worse, markedly worse. So these responder analyses were quite common when I was training, and then they fell out of favor. So this is an established technology that can dig a little bit deeper than the group-to-group comparison to look for hidden signals. You can't make decisions only on responder analysis, but it is a good complementary analysis. And what Dr. Cummings described here is, once again, exactly what we introduced in 2009, the MCID responder analysis. And I think this is something we need to go back to. So we promoted MCIDs in dementia in drug trials in 2009. It's really gratifying to see how mainstream they've become. But are the published MCIDs actually valid? Spoiler alert, they may not be valid. We don't know. Are they fully developed? No. There's a lot of development that still needs to go into MCID. So we're going to look at variable anchors, the effect of variable anchors, variable perspective, inadequate validation, and the effect of population. So taking a step back, how do you derive an MCID? Well, there are many ways. 2 common ways are distribution-based, which is not favored, and anchor-based, which is favored. So distribution-based expresses the clinical effect in terms of the underlying distribution of the measure. It's a mathematical technique. Effect size is an example where it measures signal to noise, and if there's a big signal to noise ratio, then it's more likely that you have a meaningful response. So it talks to probability of a meaningful response. But people don't support this because this is a mathematical technique that doesn't ask the patient, caregiver, or clinician. So it doesn't actually get to people. This is what you use if you don't have the other MCIDs. What people focus on, what the FDA supports, what most people support, are anchor-based. So it looks at the association between scores on administered instrument like the ADAS-Cog or CDR and another independent measure. And I'm going to show you an example, like clinician ascertainment of meaningful change, the global deterioration scale, the clinical global impression of change. So it tries to look at more global anchors. Now keep in mind, while FDA favors this, FDA does not employ MCIDs in its decisions. So RCTs, once again, may be too small, too underpowered to detect MCIDs. Then you'll see triangulation. Triangulation is mixing up a bunch of different anchor-based, maybe an anchor-based and distribution-based. I don't know if triangulation gets you closer to truth or further away. It's a little bit opaque to me. So here's an anchor, global deterioration scale. It's a staging scale. So 1 is no cognitive decline, 2 is very mild decline, 3 is mild, 4 is moderate, so mild dementia, 5 is moderately severe, moderate dementia, 6 is severe cognitive decline, moderately severe, 7 is severe. So it's a staging system. So anchoring, what it does, it asks how much change on the outcome measures, ADAS-Cog, IADRS, CDR, CDR sum of boxes, corresponds to a 1-point change in the GDS. Sometimes they'll say to a 2-point change in GDS. So it tries to anchor it to the GDS. It asks the same questions for other measures like CGIC, Clinician Global Impression of Change. So how much change, and CGIC is pretty much what I showed you in that responder analysis. 4 is no change. Then you can have minimum, moderate, substantial improvement, minimum, moderate, substantial worsening. So it asks how much change on the ADAS-Cog or IDRS or CDR-C or some of the boxes corresponds to a 1-point change in CGIC or to a 2-point change. So that's how anchoring works. This is a mathematical technique applied. So once again, going to the landmark article by Muir, Hill, Black, and Smith, looking at one of their tables is very enlightening. It teaches us 2 things. Number 1, look at the ADAS-Cog. It's analyzed by stage. You have to analyze MCID by stage of disease. MCIDs increase when you go from MCI to mild dementia to moderate to severe. The MCIDs get bigger and bigger. So they have to be analyzed by stage. And they have to be analyzed by dementia. If we start applying it to different dementias, we cannot apply these Alzheimer's disease MCIDs. You need to reanalyze it. Look at the far right. They use different anchors. So the GDS 1-point, GDS 2-point change, going from MCI to CGIC minimal at 12 months, going from MCI to CGIC moderate at 12 months, and then triangulation 2 forms. So when you look, they use different anchors, and then look at the MCID threshold column. It generated different MCIDs. So the anchors will change your MCIDs. The stage of disease will change your MCIDs. So it's not as simple as we thought. In 2009, we wrote that more empirical research is required on patient and caregiver perspectives regarding what constitutes a clinically important change. Unfortunately, that hasn't happened. Most of the studies still have a clinician-based anchor. Only 2 considered patient and caregiver anchors. That's a big miss. We're 10 years behind where the research should be. That should all have shifted over to patient and caregiver-based anchors by now. We don't know how valid the published MCIDs are. There's very little validation research in Europe, and it only found 2 studies that validated or looked at the ADAS-Cog MCID threshold of 4 points. So we don't know how valid this is. And as a disclosure, my master's thesis was looking at the validation of cognitive screening tools. So I know a little bit about validation. Why is this important? Because the tool you're using, be it a screening test or MCID, will always fit the derivation set first. So the set you derived it from, it's going to look good in that set. But you want to see, does it work in multiple other sets? Is it generalizable or does it fall apart? So we don't know if these MCIDs are valid in all the other data sets they've been applied to. So that leaves us working in the dark. So I can see and feel people's confidence in these MCIDs slowly becoming a little bit nuanced. Like you're thinking, oh, I can't just say it didn't cross the MCID. Now I have to think about what an MCID is and whether it actually is valid. Published MCIDs have variable anchors plus inconsistent methodology resulting in variable MCIDs, and MCIDs vary by perspective. We have not included the perspective of the person living with dementia now, and they have not been validated. So derivation and validation, or derivation of MCIDs has come a long, long way since 2009, but it has a long, long way to go. So when people are quoting MCIDs and say that the drug didn't pass that threshold, I want you to be a little bit more cautious and thoughtful about that. Is it realistic? Let's say they're correct. Is it realistic to achieve those MCIDs in the 18-month length framework of an RCT? So a couple of authors say, no, this is not possible. So Van Dyke looked at the Clarity Alzheimer's disease trial and said, look, in the placebo group decreased at 1.66 points on the CDR sum of boxes over 18 months. And if you look at the CDR sum of boxes column, the MCID is 1 point for MCI and 2 points for dementia. So it's almost the whole MCID that the placebo groups decreased. So by that standard, an agent would essentially have to halt progression. So Van Dyke said that's way too high a standard. Langto et al. Did analysis of the Alzheimer's disease neuroimaging data, looking at, once again, the CDR sum of boxes. And in this data, they looked at the decline rate and confirmed it with decline rates in some of the placebo groups of clinical trials. They found that only treatment saving nearly a year, this is for MCI patients, nearly a year in 18 months were considered meaningful. And in mild dementia, even a complete halting of disease would not be considered clinically meaningful by the MCIDs for CDR sum of boxes. So they said these thresholds are unrealistic. I think that's not necessarily true. What may be happening here is this may be a timescale issue. The drugs may not have had enough time to work. So this is the concept of cumulative benefits. So preventative treatments may take longer to work, may, underlined and capitalized because we don't know, that has to be proven, may take longer to work than symptomatic treatments in dementia. Symptomatic treatments being the cholinesterase inhibitors and the mantine. Surpassing MCID may be time dependent if, a big if, underlined and capitalized, curves continue to diverge. Niradal pointed out that the average effect of the Clarity AD and the Trailblazer studies may cross accepted MCID thresholds if the treatment effects were extended for 36 months. So these are two depictions that I think show that in a little bit more detail. I like this one for Peterson. The square box is the trial. And then you see after that, there's continued spread of measure. Now, this is all theoretical, right? And decline is not linear. So whenever you see a drawing that has a straight line, that's just made up. The other one shows it in a different way, that as the curves diverge, first the MCID is not met, then it's surpassed. So this is theoretical, but maybe we have a timescale issue here. The other thing to be aware of before we get into what do we do about this is progression rates vary by sample and population. Leinfeld et al. Picked that up. In their study, they wrote, our findings showed that Alzheimer's disease clinical progression in the Alzheimer's disease neuroimaging initiative cohort was slower compared to the historical placebo arms of clinical trials. This difference underscores the variability in disease progression rates between observational studies and controlled clinical trial settings, between studies with different inclusion-exclusion criteria and populations, methodology, precision, timing. So you have to be careful when we start to get into modeling which curve, which population have you chosen. So this is important because after 18 months, we don't have the double-blind controlled trials anymore, right? They end at 18 months, and there's no way the pharmaceutical industry is going to pay to continue them because they've met FDA standards, which is statistically significant. They're not going to create much bigger trials, spend tens or hundreds of millions of dollars to make a larger trial or a longer trial to get to MCID. So that's not going to happen. So what happens? People go into an open label trial. So you know they're on the trial, and they compare those patients with historical controls. So they model based on old data. So a few things to be careful about here. This could go well, or this could go horribly wrong. The rate of decline is not linear. So when you see all these drawings that I've shown you as a straight line, that's not real life. The rate of decline, as I've shown you, may vary depending on the specifics of the population. So we have a high risk of selection bias. So let's say this purple line is people on the open label trial. If we choose a historical control with a more rapid rate of decline, let's say the dotted line at the very bottom, the dark greenish line, if you choose a historical control with a more rapid rate of decline, you're going to make the treatment look better. You might even get false positive results. If you do a sensitivity analysis with multiple curves, but they're all rapid decliners, you could have a false positive sensitivity analysis. So you need to be very careful. So if you choose the wrong control group, you can prove the drug works whether or not it works. Conversely, if you choose a historical control group with a slow rate of decline, let's say the purple one is the people in the open label trial, and let's say you choose the yellow line at the top, the slower rate of decline in the control group will make the treatment look worse, might even make the treatment look harmful. If you do a sensitivity analysis with a bunch of trials with that slow decline, you can have a false negative sensitivity analysis. So you can see how this can go horribly wrong if you have the wrong control groups. So that raises a big question for me, which is who should choose the proper comparative group? How can you tell if it's the proper comparative group? Now, I'm going to upset even more people because, some people say, I'm a really well-established researcher, I'm world-renowned, this is in a very reputable journal, you should believe us. That's really not enough. There's a lot of distrust in the field. The skeptics are distrustful. At this point, this needs to be 100% transparent. How are these controls selected? Can it be reproduced? Is it reproducible? And so it really needs to be justified in 100% transparent fashion. Otherwise, there will always be critics of the open label studies. So are there better ways to measure meaningfulness, time saved, is a new concept that I think is brilliant and is a big breakthrough. So the time-saved approach, a different way to look at clinically meaningful differences, determine how much extra time it takes for the treatment group to decline to the level of the placebo group. So how much time have you saved? First time I looked at that, I said, is that survival analysis? And I'd really ask any methodologists who are listening, tell me, is that survival analysis when we get to Q&A? Because there's a whole methodology around survival analysis we could tap into and gain experience in. So time saved has two major benefits, and Langto, I think, outlined these very well. The first one, persons living with Alzheimer's dementia do not use the vocabulary of clinical trial outcome measures or speak in terms of point changes on scales. Rather, they appreciate value and converse in terms of abilities, preserving them, the degree to which they retain, and of time. And that's something we recommended in 2009 when we said, these measures should be in terms that reflect meaningful real-life improvements from the perspective of patients and caregivers. So what does that mean? That means normal people don't go around and saying, I'm impressed by this drug because it decreases the ADAS-Cog didn't decrease by 4 points. People don't talk like that. They say, I'm impressed because it slowed down decline by 40% and preserved this many people in this stage. That is how normal people discuss, and that is how the outcome measures should be framed. So time saved is a way to communicate with patients, and it lends itself to clinical decision rules also, or clinical decision aids. The second major benefit is time saved may facilitate comparisons across trials that use different outcome measures by standardizing time as a common metric. So sometimes you try to combine two trials and you need a common metric because the outcomes are different, the MCIDs are different. Time could be that standard metric. It is better than what was used in the past. In the past, it was effect size, which is that mathematical signal to noise measure. Time saved would be a better common language that could cross all trials. So authors have published how much time saved these drugs provide. For lecanemab, it's 24.3 weeks or 5.6 months. For donanemab, it's 4.3 months on the IADRS and 7.53 months on the CDR Sum of Boxes. Theoretically, if you go past 18 months, maybe there's a cumulative benefit and that time saved increases. But we don't know. We can't assume that. That has to be proven. So how meaningful is that? Now, we're going to come back to the first principles, which is minimally important is not equal to minimally important enough to counter the cost. It depends on the cost. So if you ask me, what's the minimal meaningful amount of time saved in a non-severely advanced dementia stage? Maybe I'll say 1 day. If you tell me there's no cost, no side effects, no burden, no risk, no nothing, then I'll say 1 day. But that would be a horribly uninformed opinion because that is not reality. In reality, there are risks. There's risk of brain bleed, brain hemorrhage, low risk of death, infusion reactions. There's a burden to doing this. There's a cost to doing this. So that would be uninformed. If somebody says 1 day, it means they don't understand or they were not informed. Also, you lose more than 1 day just going for the therapy. Think of all the evaluations you have to go through. Think of all the days you're going for treatment. Think of going to the emergency department if you have a headache or side effect. You're going to spend more than 1 day. So if you see 1 day in any publication, something has gone wrong. That's advocacy. That's not science. Now, if you told me I have to do multiple MRIs, I might say 6 months. If you tell me LP, I'm a little LP averse, so I might say 9 months. Monthly IV infusion, 12 months. That I can have brain edema and hemorrhage, 15 months. It costs money? I don't know. And then combination of this. So how meaningful the time saved is has to be counterbalanced with the cost. So I've heard people say, we're moving away from MCID technology to time saved. They're not mutually exclusive. You can do both. You can develop, and I would propose people develop, I'm proposing this right now, an MCID time saved or MCITS. It won't use anchor-based technology. What it might use is probability trade-off, which factors in cost, the financial cost, the burden of IVs, MRI, ED visits, the risks of infusion reactions, brain edema, brain hemorrhage. So I'm going to tell you a little bit more about probability trade-off. So in 2009, in the systematic review, we talked about this thanks completely to Dean Ferguson, who heads the epidemiology department here. So Dean was brilliant. He brought this to us and said, guys, this is exactly what needs to be done. The value of the MCID can be empirically determined using probability trade-off. The probability trade-off answers the question, at what level of benefit does the benefit outweigh the costs? Financial costs, the side effects, the risk, the burden of administration. It really more closely approximates the discussion we have with patients. It looks like informed consent. So these bars kind of describe this in terms that I can understand better. So let's look at the green box over the low bar, the orange bar. So when presented with a probability of 25% of being cured by therapy, the patient declined therapy because the side effects were considered toxic in comparison to the benefits. So they felt that the side effects were too much, they outweighed the benefits. So that's a 25%. When you went up to 35, they still said no, 45, no, 55, no, 65, no. Then at 75%, they said, yeah, now the benefits outweigh the risks and costs. You can do this another way. You can do ping pong. You can go 25 no, 100% yes, 35 no, 95% yes, 45% no, 85% yes. You can ping pong back and forth. So probability trade-off is a very powerful tool that can be used to develop MCIDs and to be used in decision aids for individual patients. So if we move to MCID time saved, if we integrate the costs with a probability trade-off technique from the patient perspective, if we analyze with responder analysis, the darts are not all over the board anymore. We are getting much closer to a bullseye of what we really want to measure and what patients really want to hear. So the take-home messages, the roadmap, these are busy slides, but they cover everything we've discussed. You can just see it in one glance. So we've moved beyond the RCTs failed because they did not meet published MCIDs. I think that's absolutely correct for the skeptics to raise. It's perfectly correct. But that's the start of the conversation, not the end of the conversation. We now have a more nuanced and deeper understanding of MCIDs and of the trials themselves. We recognize the published MCIDs may not be accurate. They're definitely not fully developed. They lack consistency in methodology. They're developed using different anchors, generating different results. They're rarely validated. We don't know if they work. We don't know if they're valid in these other groups. They rarely employ the most important perspective of all, that of the patient. And it's possible in MCI and early dementia to include patient perspective. It varies by the perspectives, patient, advocate, clinician, payer, regulator. It may be time dependent. It may take longer to cross those MCID thresholds if the curves keep diverging. That's a big if. MCIDs can be analyzed with responder analysis, and we presented an MCID responder analysis in 2009. It's time to start looking at that, and can be used with time saved, the MCID time saved. But if we're doing MCID time saved, we may be able to use 2 double-blind controlled trials and combine them and get to an MCID. We will probably have to look at open label studies, and then the comparators are critical because the comparators can give you false negatives, false positives. They can prove anything if you're not careful with your comparator. With respect to disease-modifying trial RCTs, they were never designed to detect MCID. FDA does not use MCIDs in decision-making. There was no incentive for drug companies to spend tens or hundreds of millions of dollars to make even bigger trials or longer trials to get to the MCIDs. So the RCTs may be underpowered. They may not be large enough to detect the MCIDs. It's not surprising to me they didn't cross that MCID range. Once again, maybe the trials didn't cross MCID because the drugs aren't good enough as a group, but maybe there are subgroups within the trials that do benefit. MCIDs will be more useful when we combine data from multiple studies, but on the same drug. So we cannot do a meta-analysis with different drugs combined. And I thank one of my practice partners for forwarding meta-analysis. So recently there was a meta-analysis that looked at 13 monoclonal antibody trials. Only one was lecanemab, only one was donanemab. The others were failed drugs that have not made it to market, and they combined it. Because I guess you can't do a meta-analysis with 2 studies, but it's not appropriate to do. They used effect size because the different studies didn't have common metrics. So they used effect size as the common metric. As I said before, I think time saved would be a much better metric. We now are starting to talk about the possibility that prevention may take longer to achieve and may not be achievable in an 18-month RCT. So therapies that prevent development of a disease while in the preclinical early stages may take years to demonstrate effect. And maybe the dementia RCTs were not long enough. That has to be proven. And as I said, in the open label studies, we need to be very careful. Keep repeating to yourself, meaningful change is not equal to meaningful enough to counterbalance cost, inconvenience, and risk. So where do we need to go? Last slide. The needed research. I propose we need MCID time-saved research analyzed via responder analysis. We need our experts in epidemiology, perhaps the decision aid methodologists, to help us figure out how do we calculate time-saved MCID. Is it probability trade-off? Is it another technique? Once we have responder analysis, we can calculate number needed to treat, but always insist you also see number needed to harm. These are drugs that have inherent potential harms. These can be used to calculate odds ratios. We need to determine the optimal methodology for modeling control groups in open label studies. We have to make sure we're using optimal historical data so we avoid exaggerating results or getting false positives or false negatives. And as I said, even a sensitivity analysis can give you false positives or false negatives. Here's a completely outside the box idea. Can we develop MCIDs for persons living with dementia and their caregivers after they've completed a course of therapy? We haven't had a chance to do that yet. Now we can do it. So they've had the lived experience. They are fully informed on what these trials mean, what this treatment means. This would be hugely rich information. We need pharma, or we need independent researchers with access to the raw trial data to rapidly reanalyze data using MCID responder analysis. This can be done in 1 day. This can be done in 3 hours. So this should be done. Now, I'll be honest with you, I'm going to share this YouTube with pharma. And some people have told me, the pharmaceutical industry is not going to do this because remember that funnel plot? That funnel plot went from 237 patients to 18 patients. If you start doing responder analysis, that group gets even smaller. So that's bad for business. You have a smaller treatment group. There's a counter argument. The treatment group you then have are more likely to have a very positive effect. Positive effect is good marketing. So then you could get more people to come out and ask for these medications. So there are pros and cons, but people with access to this should really look at getting an MCID responder analysis out yesterday. We need online, rapidly updatable decision aids. Things are going to change very quickly. New drugs are going to come online. They're technological game changers. Sub-Q is going to replace IV. Community home administration is going to replace clinic. We're going to have blood-based biomarkers instead of PET-LP. And now there's a brain shuttle technology that's evolving that allows molecules to cross the blood-brain barrier. So we may be able to reanalyze some of the failed drugs, and this might decrease side effects and risks. So the message now is the same in 2009. We need targeted funding to develop patient-centered MCIDs. These drugs cost tens of millions of dollars to study. We should be spending some money to develop the bar, the threshold, the measure that tells us if they work. So that's 4 hours of discussion in, I know Dr. Boyd, too long. If you want to reach me at fmolnar@toh.ca, I can send the YouTube to you. I'm happy to share the slides and happy to answer any questions. Thank you.